And let me introduce a great experience, a great success of collaboration between African countries. It's a great experience. Let me introduce Dr. Amr Abdelaal. Professor Amr is professor of liver surgery in Ain Shams University, Cairo, and he is one of the experts in the liver transplant in our country. And he will address an important topic, the story of success of implementing the first liver transplant in Cote d'Ivoire, and how we can work together, how we can different African countries work together in a great success. Dr. Amr.
Thank you so much, Dr. Ashraf, for this nice introduction, and thank you for the organizing committee and Dr. Manal Sayed for inviting me to be with you today in Cape Town to talk about our experience and transfer of experience in living donor liver transplant and the collaboration between Egypt and Cote d'Ivoire. I'll share this lecture with my dear colleague, Dr. Kelly. I'll do my best to stick to the time as much as possible, but don't trust surgeons. Transfer of experience in living donor liver transplant. I'll pass directly to my lecture, and first is the introduction and history of living donor liver transplantation. The simplest definition of organ transplantation is a replacing of a failing organ with a new healthy one. Thomas Starzl is a father of modern transplantation. He performed the first case of liver transplantation in 1963, a successful one in 1967, and has a clinical utility of cyclosporin in 82 and tacrolimus in 91. And he's the author of the first textbook on liver transplantation, written in 69. Between 67 and 75 European centers performed liver transplantation with a one-year survival not more than 18%, till the era of cyclosporin. Jean-François Borel is the first to discover in 1972 the cyclosporin in natural fungal product, and this was the huge revolution in the field of liver transplantation. And after the era of cyclosporin, in the late 70s, the one-year survival after liver transplantation approaching 70%. Why we do transplant? Why we are in need for a program for liver transplantation, especially in our continent? Either patient, he is a handicapped patient with end-stage liver disease, completely cirrhotic liver, acidic, muscle wasting, repeated attacks of hematemesis and SPP. The second category is patient with hepatocellular carcinoma, irresectable hepatocellular carcinoma. Four main categories for indication: either cirrhotic patient with hepatocellular carcinoma, metabolic liver disease, or acute liver failure. And this is the shape of the liver after transplanting patient with left lateral segment, beautifully vascularized after the arterial and venous anastomosis. History of liver transplantation in Egypt. First case of liver transplantation performed in Egypt in pediatric age group in 1991. And it was published as a living-related liver transplant in Africa, first trial. After that, we have an adult case, adult-to-adult liver transplantation. It was always living donor liver transplantation, and it was published by Professor Negi Habib and Dr. Tanaka. It's just a hypothesis at that time. But the breakthrough, it was in 2001. Two huge hospitals recognized the concept. The concept is liver transplantation is not a simple operation. It's a program. It needs a huge collaboration between a center performing a huge number of liver transplantation. That's why now the overall transplanted cases in Egypt and many centers approaching the teams performing liver transplantation is nearly 7 teams. Overall transplanted cases 5,200 cases. Two very important questions in liver transplantation: why we don't have a cadaveric transplant in Egypt? Is it religious or cultural? The first point, religious, is not religious. In 1982-86, the Islamic theologians issued, who became now known as the Amman Declaration, in which they accepted brain death, and they accepted retrieval and transplantation of organs from living and cadaveric donors. Then I thought it's a cultural problem. Very simple. The making of a mummy in the Egyptian history, the pharaohs usually retrieve organs, one very essential step in the making of mummies is retrieval of organs. And here we can find incision of the abdomen, removal of organs. They are afraid of the bacterial infections, and that's why they retrieve all organs before the making of mummies. It's not cultural. Our team experience, I can consider our team or our generation the second generation performing liver transplantation in Egypt. We have two programs, or my team have two programs of liver transplantation, one in a military hospital and the other in a charity, a completely free hospital. It's a public hospital. We are performing, till the last 6 or 7 years, we performed 520 cases of living donor liver transplant. Nearly 25% of our cohort are in a pediatric age group. This is the annual number of transplanted patients per year. We have a lot of challenging cases. When we start any emerging program, we have a lot of restrictions. And by time now, we are transplanting nearly from 22 years. We have first dual liver graft in 2016. We have a domino liver transplant. In a setting of living donor liver transplant, it's very hard to accept patients with fulminant hepatitis. But we accepted 5 cases of fulminant hepatitis with good results. We accept patients with chronic portal vein thrombosis, patients with locally advanced after TARE, down staging with TARE. And we have combined simultaneous liver and kidney and sequential liver and kidney transplant. And we performed the second and third case of dual liver graft in 2019 and 2020. The issue of today's is a transfer of experience and ways of collaboration. I think the first and most important issue is to recognize that liver transplantation is more than just an operation. It's a program. It needs a collaboration between all subspecialties, all active local team with all subspecialties, hepatologist, hepatic surgeon, ICU and anesthesia, interventional radiology, medical oncology, nursing staff, and complete collaboration with other team performing this operation with high volume work. And that's what we performed with Service de Chirurgie Hépatique Bilio-Pancréatique et Transplantation Hépatique à l'Hôpital Édouard Herriot. We make a very nice collaboration between the center in Egypt in 2001. And we found that in countries without cadaveric program, living donor liver transplantation can be rapidly evolved only in reference to the other established centers. What we need in emerging program to develop a center, a liver transplant center, we need to find a financial support. We need to find a partnership at different levels, governmental, international institutions, medical and surgical teams, and university hospitals. And training and educational program. It has to be in a qualified and specialized medical and surgical institutions. Very important to be at least for 1 year, complete collaboration, as I told you, and then starting a clinical program under the responsibility of the multidisciplinary qualified team. The surgical part is very, very difficult, and it needs gradual hands-on and complete understanding of the two teams. We concluded in our study that living donor liver transplant is considered the standard procedure in other living donor liver transplant and of crucial importance in countries in which cadaveric transplantation is not yet feasible. Transfer of experience is possible and avoids most of the serious complication and bypass part of the learning curve of this difficult procedure. After 40 collaborative procedure and 20 own cases, results do not significantly differ from those of experienced centers, even in more difficult cases. First model, we applied our first model after we have a well-formed Egyptian team with the Saudi German hospital in Jeddah. We started to prepare the centers, all the checklist, all the preparation. OR usually for living donor liver transplant setup, no compromise. Safety of the donor and recipient of utmost importance. All the equipments needed, we prepared all the equipments. To have a license for liver transplantation is very, very difficult. Instruments, microsurgical instruments, retractors, as I told you, no compromise. At the end, we have the license for liver transplantation. We started our program with the Saudi team 3 years ago, and now we performed in 3 years. This is one of our cases, a bacterial preparation, cirrhotic liver on the left side, and this is a right liver from his son. one of our cases of living donor liver transplant. One of the most important part in transfer of experience is that we have now in Saudi German hospital a well-formed team. They can perform many operations of hepatobiliary surgery efficiently with no help. And for the part of living donor liver transplant, as it very, very crucial, now we performed, celebrating one of our cases, we performed, as I told you, 13 cases of liver transplantation and nearly 80 hepatobiliary advanced surgeries. Last part of our presentation I'll share with Dr. Kelly, our experience with Cote d'Ivoire. The most important point or most important objectives of our team during collaboration with the African teams is raising awareness of the African doctors about the medical conditions, creating channels of communication between African countries, sharing experience and providing support of the African doctors as regards the indication, and then transfer of the experience in the field of HPP surgery and liver transplantation, and to helping some of the African countries to develop a program of liver transplantation. Part of our memories in Trishville Hospital with Dr. Kelly. Our team, our endoscopist, hepatologist, and intensivist, and nursing staff performing, choosing the hospital of cardiothoracic surgery to be the part which hosts the living donor liver transplant program. Dr. Kelly will continue the part of the liver transplantation performed in the model in Cote d'Ivoire, but we can conclude that liver transplantation is the only way to help patients with end-stage liver disease. It's a teamwork that needs active interaction between different specialties. Transfer of experience is possible and avoids most of the serious complication and bypass part of the learning curve of this difficult procedure. It's demanding, tough, and costly procedure. However, it is rewarding and should be continued on a larger scale. Concerning the pediatric age group, we usually it was a contraindication to transplant babies before lower than 12 kilogram, and we started nearly 3 or 4 years ago to accept 8 kilogram and 5 kilograms, and now we have a lot of cases transplanted at 5 kilogram, 5.2. Really putting a smile on the faces of these babies is our ultimate goals. Transplanting many other, as I told you, I think we are the highest cohort of pediatric transplantation in the Middle East. Lastly, we founded the ELTS, Egyptian Liver Transplant Society, with the International Liver Transplant Society and the Transplantation Society, and we'll be very honored to invite you all in Cairo, November 17 to 19, to share with us the first International Congress of the International Liver Transplant Society. We'll be really very happy to invite you all to be with us in this great event. Thank you so much.
Dr. Kelly.